Good morning to all. Today I'll be talking on uh, some of the oncogenic viruses, the most important human papilloma virus and member of herpes viridae family, that is Epstein-Barr virus, and polyoma viruses that belongs to polyoma viridae family. And these three important aspects I am going to discuss today. Before talking about the human papilloma viruses, we have the case scenario related to that. A 35-year-old man presented with dysuria and small groups of bumps in the genital area. On examination, fresh flesh-colored exophytic lesions are seen on hands. Visual examination identified genital lesions measuring 5 mm on the external urethral orifice. Cystoerythroscopy also revealed a small non-papillary tumor on the urethra extending 5 centimeters from the urethral orifice with a normal urinary bladder. Transurethral resection was performed and diagnosed as urethral condyloma acuminatum based on histopathological examination. And 2 months after the surgery, the patient presented with gross hematuria. Again, non-cystoscopic examination of bladder shows small papillary tumor, and on again histopathological examination suggestive of grade 1 non-invasive urethral carcinoma. So what we have to understand from this case is the lesion started as small group of bumps on the urethral orifice, and post-operatively this have been seen as a case of grade 1 non-invasive urethral carcinoma. So some of the skin lesions or mucosal lesions are acting as precancerous conditions. Later they are developing into the cancerous conditions. With this little case scenario, we have to read about the human papilloma viruses, and the major features of this human papilloma viruses are they belongs to the Papaoviridae family. Papavo means PA stands for papilloma viruses, PO stands for polyoma viruses, and VA stands for vacuolating viruses. So this is a Papaoviridae family, consists of all these things. And these are small viruses, size around 50 to 55 nanometers, which are naked virus with icosahedral capsid. And the genome is supercoiled with a double-stranded DNA genome, which encodes for early 8 proteins designated from E1 to E8, and 2 late proteins designated as L1 and L2 genes. And most important thing is these papilloma viruses can't be grown any kind of cell line cultures. Then if you see this classification of the human papilloma viruses based on DNA homology and tissue tropism, and also their association with the cancer production, they have been divided into 16 groups, and again the 16 groups have been divided into 100 serotypes. Among them, around 60 serotypes are associated with common warts, and whereas 40 are associated with genital warts. And the serotypes 1, 2, 3, and 4 are keratotropic, and also the epithelium of skin. So they can get multiplied in the keratinized tissues of the body. And other important serotypes are 11, 16, and 18, of course 31 and 33. These are all mucotropic, which infects the genitourinary tract, oral mucosa, and respiratory mucosa. So finally, these human papilloma viruses are keratotropic as well as mucotropic viruses. These viruses are replicated. The early genes of these viruses are responsible for the growth of infected cells and replication of viral genome. So E1 and E2, the E1 and E2 are responsible for the replication of this virus, and E6 and E7 early genes are responsible for their cancer production due to the inhibition of tumor suppressor genes 53 and also the RB respectively. And the late genes causes excretion of dead cells from the upper layers of infected skin. This is how these early and late genes are responsible for their replication of the viruses and also the carcinogenicity of the viruses and the excretion of these viruses from the dead cells. Genesis, the reservoir for these infections or the patients who are suffering with skin or genital lesions, not only the skin, even the lesions in the mucous membranes, of the oral cavity and also the respiratory tract. And source and transmission, skin to skin contact with patients is important for the transmission. Remember, these are all highly contagious viruses. So these are all highly contagious, and so the contact with the people who are suffering with these lesions, this kind of lesions are more infectious. And contaminated fomites near the swimming pools, like contaminated bath towels or any other fomites, also can transmit these viruses. And sexual contact by genital to genital infection, the sexual contact also possible. Just the contact with the person who is suffering the disease may not suffer with the genital lesions, but sexual contact can transmit the genital lesions from one person to other person. After an incubation period of 2 to 3 months, the lesions may appear. Of course, in case of genital infections, it would be around 1 to 20 months. But in case of the skin and mucosal warts, we can see them within 2 to 3 months. Replication and its pathogenesis. The virus replicates in the basal layers of the skin. It replicates in the basal layers of skin and mucous membranes and responsible for cell growth and also the thickening of basal and prickle cells of stratum spinosum to produce the warty lesions. And here if you see the schematic representation of this cross section of the skin, see this is the stratum corneum of the skin, and this is stratum lucidum of the skin and stratum granulosum of the skin, and here we have the stratum spinosum, and this particular area mainly involves with this particular viral infection. This after the viral replication, the keratocytes gets enlarged with a halos around the small nuclei, and that is the hallmark of the human papilloma viral infections. The keratocytes with halos around the small nuclei are known as cheilocytes, and this cheilocytes appearance is a hallmark of this human papilloma viral infections. See here you can see the cells with that's the enlarged keratocytes with halos around the small nucleus. So inside this you can see the nucleus, inside the cell you can see the nucleus and its enlarged cells. Like this, many of the cells are seen in this stratum spinosum of the skin. How the clinical disease of this viral infections is present? Present in the cutaneous warts, which are appears as flesh colored. See, these are all the flesh colored exophatic hyperkeratotic papules. That's again due to the benign hypertrophy of the dermis and hyperkeratosis, and also the hyperkeratosis of horny layer of the skin. And these common warts are mainly produced by the serotypes 2 and 4 predominantly found on hands and fingers. The age group is mainly children. Commonly, the children are commonly affected with this kind of common warts. And other kind of common cutaneous warts are plantar warts. These plantar warts are also known as verruca plantaris. These are all plantar warts. You can see here, these are all the warts. And these plantar warts are seen in the soles and tend to be deeper, and so they are painful and commonly seen in adults. And the anogenital warts, also known as condyloma acuminatum, about which I discussed in the case scenario given, and 90% of the genital warts are benign, which are produced by the 6 and 11 serotypes of this human papilloma virus. But some of these viruses are responsible later, viral infections later causes for dysplasias and also the squamous cell carcinoma of the penis in male. And usually they appear as a single or group of bumps. See here the lesions, you can see the group of bumps in the genital area, which may be small or large, raised or flat, or sometimes looks like a cauliflower like appearance. See here you can see like a cauliflower like appearance. These are known as condylomata acuminatum or condylomata acuminata. And some are pre-neoplastic, especially the genital warts produced by 16 and 18 serotypes are pre-neoplastic in condition, and later they may convert into the full-fledged cancerous conditions. And they mainly responsible for cervical and urinary bladder cancers, and also the cervical intraepithelial neoplasias also seen. Here you can see the condyloma acuminata on the genitalia. Let me take the other pen so to visualize it proper. See, these are all the condylomata acuminata in case of female genital tract, and also the human male glans penis. You can see that condylomata acuminata like this, and around the anus also you can see the condylomata acuminata like this. Respiratory or laryngeal papillomata mainly produced again by the 6 and 11 serotypes, commonly seen among the preschool children, and usually they get transmitted from the mother to the baby. And also the sexually active adults, due to the abnormal sexual practices, also may get infection. And sometimes it results in squamous cell carcinoma of the tonsil. Here this is the normal laryngeal cords, and but whereas vocal cords, and whereas here you can see the lesion here. This is the normal vocal cord, the larynx, and whereas this one is the growth. And oral papillomata again produced by the 6, 11, 16 and 18, and in the oral mucosa you can see the lesions like this. See how the lesions are appearing on the tongue as well as on the oral mucosa. Another variety of presentation is focal epithelial hyperplasia produced by the serotypes 13 and 32, and this is a rare form of oral human papilloma viral infection and manifests as multiple single, smooth or nodular lesions are present on the lower lip and also the buccal mucosa and also the tongue. It is definitely a precancerous condition. It's definitely a precancerous condition, and this focal epithelial hyperplasia is also known as Hex disease. It's also known as Hex disease. Here you can see the single lesion here on the lip, or inside the lip you can see the lesions as multiple lesions. The multiple lesions inside the lips. Association between the type of cancers and the human papillomavirus is the cervical cancers. Almost all the cervical cancers are associated with the human papillomavirus, and vulvar cancer in the female, in 69% of the vulvar cancers are associated with this human papillomavirus, and 75% of the vaginal cancers 63% of the penile cancers, and 91% of the anal cancers, and the 72% of the posterior wall of the throat cancers are associated with this human papilloma virus. And if you see the cervical cancer versus human papilloma virus, about 10% of women with the cervical human papilloma viral infection may develop the risk of cervical cancer after nearly after 10 years of the genital warts. And this is the second most common cancer in the females after the breast cancer. The first one would be of breast cancer. After the breast cancer, this is second most common cancer among the females. The clinical manifestations of the cervical cancers are irregular blood spotting between the menstrual cycle and postmenopausal spotting or bleeding also possible, and bleeding after sexual intercourse sometimes possible, and increased vaginal discharge sometimes with foul smelling also, possible. Sometimes with foul smelling also possible in case of genital warts. So genital warts complicated as cervical cancer. The cervical cancer by histopathological examination. See, this is the normal cervix, and also on histopathology you can see the normal cells. Whereas if you see the other things like cervical intraepithelial neoplasia, this is the kind of lesion you can see in the cervical intraepithelial neoplasia, also like ulcer formation. And if you take the biopsy or the pap smear, then you can see the multinucleated cells. See, the many nuclei are seen, and when compared to the normal nucleus. If you see here, this is the normal morphology of epithelial cells, where the nucleus is very, very small with a lot of cytoplasm. But if you see in this cell, see the main nucleus are two nuclei are there inside, and another cytoplasm also, the volume of the cytoplasm also reduced. This is another normal epithelial cell, but these are cervical cells which undergone for the cancerous change. And the next stage is the dysplasia of the cervical epithelial cells, where you can see the epithelial cells with a lot of nuclei and abundant decrease in the cytoplasm. So there is a lot of nuclei there within the cell. And again, in this particular stage of the disease, you can see the extensive lesion like this. This kind of extensive lesion is produced, and you can see the bleeding spots also. These are all the bleeding spots from here. And this is the full-fledged case of cervical cancer, where you can see the it's big ulcers or masses on the cervical area. And by the staining procedure, by the staining of this particular tissue, you can see the large number of cancerous cells. These are all the cancerous cells. This group of cancerous cells are produced with a lot of dysplasia. This is how the cancer cells are seen on cancerous condition of the cervix in case of females are seen. Diagnosis: the warts have to be biopsied. The biopsied material of the warts is the best, and histopathological examination of these warts will show the hyperplasia of the prickle cells and also the hyperkeratosis. Here the hyperplasia and hyperkeratosis, you can see these cells are known as chyelocytes. These are known as chyelocytes. These chyelocytes are nothing but the virally infected cells of skin, which are nothing but keratocytes, the virally infected keratocytes. And pap smear of the cervix will show the round and coalesced squamous epithelial cells in clumps. See, this is again the here if you see this is the normal epithelial cells, whereas here if you see, you can see large number of squamous epithelial cells which are coalesced with each other. This is how we can identify the changes, epithelial cell changes in the cervical cancer. And in case of cervical, full-fledged case of cervical cancer, better to go for a cervical biopsy. And we have other molecular methods also, like DNA probes and also the PCR, to know the strain level or serotype level of this particular viruses. Serotypes identification done by PCR method. Usually regressed during the course of time. But remember always, the cell-mediated immune response plays a major role in the recovery. If the people are lacking the cell-mediated immune response, then there is a possibility for this particular disease to progress very badly. And removal is possible by means of cryotherapy, where we have to use the liquid nitrogen, and laser therapy and surgical removal also possible. And other drugs available are imiquimod. This imiquimod is available in 5% cream, which has to be applied for 8 to 12 weeks. It boosts the innate immune system or immune response. Boost up the innate immune response by producing interferon alpha and tumor necrosis factor alpha, and also some other interleukins, which are responsible for enhancement of immune response by the host. And this imiquimod also associated with rashes. A skin rash, sometimes it's a kind of rash will appear, and also in some of the cases the disease or the warts will be increased for short period, and then it starts regression. So imiquimod, the first 1 or 2 weeks, it's a bit difficult to tolerate, but once you tolerate, the results will be very, very good. The recombinant vaccines are available in the form of Cervarix, prepared with 16 and 18 serotypes, and a Gardasil 9 with adjunct, that's another 6 and 11 serotypes that's available. And all the female children at the age of 12 years, it has to be given in 3 doses. That's at the age of at 0 date. After that 1 month, you have to give the second dose, and after 6 months, we have to give the third dose. And protection offered by this course of vaccination is around 8 to 11 years. And next important thing is safe sexual practices have to be practiced. Always have to go for the barrier methods for the prevention of transmission of this particular viruses during the sexual intercourse. Under oncogenic viruses, before going for that, we have the case scenario again here. The 17-year-old female is brought to the medical OPD with the sore throat and also the fever since 1 week. She has extreme fatigue and confined to bed for the last 3 days. She is not on any medications. On examination, body temperature was 101.3 degrees Fahrenheit, and markedly enlarged and erythematous tonsils covered with the white exudates. And she has severe cervical adenopathy or lymphadenopathy with mild tenderness. CVS is normal, and other systems of the body also normal. And then the amoxicillin drug has been started, assuming that it's in a case of streptococcal pharyngitis. And a rapid streptococcal antigen test also negative. It's not actually the streptococcal infection. 2 days later of the initiation of this antibiotic course, complained about the red rash from head to toe. So this is how the Epstein-Barr viral infections or infectious mononucleosis will present. We will learn about it now. Virus is a member of gamma herpes viridae. A subfamily belongs to the herpes viridae family. It belongs to the herpes viridae family, right? And then and it's identified in 1964 from a case of Burkitt's lymphoma. And these Epstein-Barr viral infections are common in early childhood and late adolescence period. And the source for this infection is oropharyngeal secretions of the human beings. The human beings may be symptomatic or asymptomatic human beings. The oral secretions or oropharyngeal secretions are the main source. And transmission, for the transmission always requires large quantities of the inoculum or large quantities of the oropharyngeal secretions. So the prolonged kissing or wet kissing is responsible for the transmission of this particular viral infections. Pathogenesis, an entry of this virus into the body, they gets attached to the CD21 and CR2 receptors in the B cells on pharyngeal, which are present on pharyngeal epithelial cells, and then it enters into the latent phase without completing the replication cycle. As you all know that the members of the herpes viridae family are having three important properties. One is latency and relapse of the disease due to the replication of the virus. So the latency, replication and relapse is the three important properties of this herpes viridae family. So soon after its entry, it undergoes a latent phase and it won't complete the replication cycle. And after that, the majority of infected cells are eliminated by the immune system, but a few remain for lifetime. And these viruses which are present in the B cells on reactivation produces the clinical manifestations related to this infectious mononucleosis and also responsible for shedding of the viruses through the oropharyngeal secretions and acts as source. These oropharyngeal secretions again acts as source for new infection, right? And then if you see the flow chart related to the pathogenesis, they get attached to the B lymphocytes and results in B cell proliferation, and uncontrolled B cell proliferation results in the formation of heterophil antibodies which can agglutinate the sheep and horse red RBCs, horse red cells, and this B cell proliferation leads to the Epstein-Barr viral antigens on their surfaces, and after that it will be subject to the T lymphocytes, and T lymphocytes gets activated, results in the formation of atypical lymphocytes, especially in the peripheral smear of the blood. And this T cell activation results in the enlargement of liver, spleen and lymph nodes due to the increased burden in the immune system of the host. And then these infected B cells become immortal and continuously they produce this large number of antibodies which acts as autoantibodies. Disease produced by this particular Epstein-Barr virus is infectious mononucleosis, also known as glandular disease because of the severe lymphadenopathy of the cervical glands, and also the kissing disease because the wet kissing mainly transmits this infection, so it's also known as kissing disease. Young adults in developed countries are commonly suffers with this particular infectious mononucleosis. The people who are suffering with infectious mononucleosis will suffer with headache, fever, malaise, and severely pharyngitis or sore throat. And in this sore throat, you can see the discharges from the tonsils with white patches over the tonsillar area. See the white patches on the tonsillar area you can see. And cervical lymphadenopathy will be seen, which is in a severe form of cervical lymphadenopathy is seen. And maculopapular rashes are seen on the body, followed by the usage of ampicillin drug. So here you can see the rash, the maculopapular rash in all over the body, but it is always possible by the introduction of the ampicillin drug, and hepatosplenomegaly also present. And then another important presentation is hairy leukoplakia, and this is hyperproliferation of lingual epithelial cells, especially among the AIDS patients. See, this is what we call hyperproliferation of the lingual epithelial cells, the epithelial cells of the tongue, especially among the people who are having less CMI, who are having less CMI. That's in case of AIDS patients, and why these lesions are seen as white gray lesions on the tongue, that is hairy leukoplakia. Malignancies associated with the Epstein-Barr virus is one is the Burkitt's lymphoma, of course, the common in African countries. This is the tumor of joy in children and also the young adults. And in case of falciform malarial infection and HIV infection, these two infections can stimulate the Epstein-Barr virus, which is usually present in the most of the individuals in the form of latency. And when these people are get exposed to the falciform malaria and HIV infection, they stimulates the Epstein-Barr virus present on the infected B lymphocytes and cause for the production of the disease. And this is the see here you can see this is the one where you can see the involvement of JA in children with the case of what we call this is Burkitt's lymphoma, right? And then number 2 is the nasopharyngeal carcinoma. It's very common among the Chinese people who are eating the salted fish, which consists of a lot of nitrosamines, and herbal snuff, which consists of forbol esters. These two acts as the cancers. The two acts as an derangement of the epithelial cells of the nasopharynx, which results in the hyperactivation of these infected B lymphocytes and results in nasopharyngeal carcinoma. And here you can see the nasopharyngeal carcinoma, the lesions of nasopharyngeal carcinoma here, and this entire thing is mass related to the nasopharyngeal carcinoma. And here the schematic representation of this one in the head and neck region. And the next one is the what we call this Hodgkin's lymphoma. Here you can see the lesions, the lymph node enlargements, cervical lymph node. Not only that, you can see in the PET scan, you can see all these lymph node enlargements. So in various areas of the lymph node, you can see this inguinal lymph node enlargement, and you can see the intra-abdominal and also the intrathoracic. All these areas, even axillary lymph nodes, all the lymph nodes are enlarged here in Hodgkin's lymphoma. And also they're responsible for non-Hodgkin's lymphoma too, and chronic fatigue syndrome also another problem with this viral infections. Chronic fatigability and the long term for more than years together, the people will feel about the fatigability for the simple works, simple activities. This blood smear shows the atypical lymphocyte. These are all the large number of atypical lymphocytes, and they shows around 70% of the total WBCs. And another important test to be done to diagnose this Epstein-Barr viral infection is Pal-Burnell test, which is a tube agglutination test, and of course this heterophil antibody detection test. Heterophil antigen means first we have to know what is heterophil antigen. Heterophil antigen is the one which present in the different species and kingdoms. And the antibodies which are produced by the Epstein-Barr virus can be detected by using the RBC suspension. So the antibodies which are produced against the Epstein-Barr virus can react with the RBC, means there is some relation between the Epstein-Barr virus and the antigenic structure of sheep RBCs. So here what to do is we have to take the serial dilutions of inactivated serum. Inactivated means we have to keep the serum at 56 degrees centigrade nearly 6 to 8 hours or overnight. Then you have to lyse the complement. We have to lyse the complement. So once you lyse it, then that kind of blood, serum has to be used, and it has to be mixed with 1% sheep RBCs suspension in the equal volume. And this mixture has to be kept at 37 degrees centigrade for about 4 hours and look for agglutination reaction. If the agglutination titer is more than 1 in 256 dilutions, then it will be significant titer. But remember, there are some pitfalls are there with related to this test, that is non-specificity, and also the false positive reactions are seen with this particular test. And heterophil antibodies will be seen maximum in third week and of the disease and disappear by third month after the disease. So within this period, if you do this test, it will be useful, otherwise it gives false negative results. And the test also would be negative in the age group less than 5 years age and elderly people. Among these two people, the test becomes negative. And commercially available new slide agglutination test also available, which is popularly known as monospot test. This is a rapid test and turnaround time also very less for this particular test. That is antibody tests are available for the detection of viral capsid antigen. They are in the form of IgM antibody detection and IgG antibody detection, which subsequently which may shows the current infection as well as past infection. And antibodies for nuclear antigen also available, which indicates only the past infection. And detection of Epstein-Barr viral DNA, that's by means of PCR, or that's RT-PCR for quantification, that is real-time PCR for quantification also available for the accurate diagnosis of Epstein-Barr viral infections. And treatment, we have to go for analysis and acyclovir, and monoclonal antibodies has to be given against the CD20. CD20 antigen mainly present on the B cells. This is present on the B cells and acts as acts as an antigens, and this to receive the concerned antibodies. So here the monoclonal antibodies to the CD20, which is available in the rituximab in the market, can be used for the treatment of this particular Epstein-Barr viral infections. Every day, a few things about it. They are small DNA naked viruses with again the icosahedral capsid, and there are 5 known human polyomaviruses are there. One is BK and JC viruses, which are the BK and JC are the initials of the patient from whom they have been isolated, and KI and WVU viruses belongs to the names have been given depending on the institutions from where they have been identified and established their identity. And the MC virus, this is a marker cell carcinoma virus. All these 5 viruses belongs to this polyomaviridae family. Transmission, most of them are transmitted through the close contact, and fecal-oral and respiratory route also possible, and blood transfusions and transplacental transfusion also possible, and it can get transmitted through the semen in case of male, and organ transplantation also can transmit this particular viruses from one person to the other person. BK virus, this occurs in childhood and the seroprevalence rate by the age of 10 years is around 65 to 90%. That means by the age of 10 years, 65 to 90% of the individuals or children gets infected with this one. And these viruses will get replicated in the kidney cells and seen in the urine cytology as decoy cells. And these decoy cells are nothing but the cells, the virally replicated cells in the kidney are seen in the form of cylinders. See, in the form of cylinders, and these sometimes they can see in the here also you can see them in the form of cylinders. So these cancer cells are arranged in the cylinders, and those described as decoy cells. And replication followed by replication of this virus occurs always followed by the immunosuppression, and also the transplantation, post-transplantation cases, and followed by the HIV infection and during pregnancy due to the decreased cell-mediated immune response. Due to decreased cell-mediated immune response, they get multiplied and produces their own relevant clinical manifestations. Manifests in the form of nephropathy, the infection of the BK virus in the kidney results in the form of nephropathy, and seen in the form of severe hemorrhagic cystitis with tubulitis. Tubules are involved, tubules of the kidney are involved, and also the hemorrhagic cystitis is present. Interstitial inflammation, fibrosis, and also atrophy seen, and especially among the renal transplantation patients, it leads to the graft rejection, in the among the recipients of the kidney. And here you can see the cells, the highly inflamed cells with this particular viruses are replicated cells in these viruses. Due to these viruses in the kidney, here you can see these are all the clear-cut cancerous cells. These are all the clear-cut cancerous cells. Of course, these are all the normal cells, and these are all the clear-cut normal, cancerous cells in the either in the bladder or in the tubules of the kidney. Yes, the growth occurs in the human fetal glial cell cultures, and the viruses, even though they're present in the body, they can't get multiplied as long as the CM is intact. The reactivation occurs followed by the HIV infection, or in case of AIDS, and also in case of Hodgkin's disease, and in chronic lymphocytic leukemias. And it produces progressive multifocal leukoencephalopathy, otherwise called PMLE, which is characterized by the subacute demyelination with the visual and speech impairment, memory loss, and dementia present. So this is how the brain tissue will appear, followed by this JC viral infection, that is progressive multifocal leukoencephalopathy, that is the infiltration of the leukocytes in various parts of the brain tissue. This brain tissue has to be given only by the postmortem examination, and histopathological examination will show the abnormal oligodendrocytes, and the electron microscopy will show the multifocal leukoencephalopathy, which is in progressive in nature. And renal immunohistochemistry will also show the BK virus genome, and urine is the best for the BK as well as JC virus. They can be cultured in the fetal glial cell line cultures, and IgM antibody detection by the ELISA also useful, and PCR from the CSF for BK and JC virus are more sensitive, and treatment for these viruses has not yet established it. So only we have to give supportive treatment. Virus 8 is a member of gamma herpes viridae again, and discovered in the 1994 from a case of Kaposi's sarcoma, and the infects the B lymphocytes, and have the high prevalence in Africa and low prevalence in North America, Asia, and Northern European countries. And transmission is possible among the homosexual men, and also followed by the organ transplantation, and followed by the drug abuse age, and through the blood transfusions, these viruses can get transmitted from one person to other person, since it infects the B lymphocyte. So its blood transfusion is always possible. The disease manifestations of this human herpes virus 8 are the lesions are seen among the immunocompromised individuals in the form of Kaposi's sarcoma, and which is soft tissue sarcoma of the vascular origin, and they appears as a red to purple color growth. See here, that appears as red to purple colored growth on mucosal membranes of the oral cavity or the gingiva, and also produces primary effusion lymphoma in the body cavities, otherwise called they are also called as body cavity lymphomas. And Castleman's disease, nothing but lymphoproliferative disorder of B cells, also seen, was also produced by this human herpes virus 8, And among the immunocompetent individuals, if the people have intact CMI, they suffer simply with fever and rash, not more than that. And treatment, the response to the foscarnet, ganciclovir, and also foscarnet, ganciclovir, and also pseudofovir. This is about some of the oncogenic viruses of human importance, and there are many more oncogenic viruses are there. I am not going to discuss in this particular session. We will discuss it later in another session, right? Thank you very much.